Palm Beach State College. Emergency medical technician. Vital signs, pulse. The student will describe the therapeutic effects of the equipment/procedure. Assess patient's heart rate. The student will describe the indications for the equipment/procedure. All patients. Every 5 minutes for unstable patients, during reassessment. Every 15 minutes for stable patients, during reassessment. The student will describe the contraindications for the equipment/procedure. None. The student will describe the possible side effects to the use of the equipment/procedure. None. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Explains the procedure to the patient. Locate the following pulse point. Carotid pulse, unconscious adult. Brachial pulse, pediatric. Radial pulse, conscious adult. Femoral pulse. Posterior tibial pulse, behind medial malleolus, ankle bone. Dorsalis pedis. Identify the following. Rate. Regular, count the number of beats in seconds and multiply by 2. Irregular, count the number of beats for 60 seconds. Rhythm, regular or irregular. Quality, strong, weak, or bounding. Strong, indicates a normal pulse. Weak, indicates a weak, rapid pulse aka, thready, may be a sign of hypoperfusion. Bounding, indicates a stronger than normal pulse. Vital signs, respirations. The student will describe the therapeutic effects of the equipment/procedure. Assess patient's breathing rate. The student will describe the indications for the equipment/procedure. All patients. Every 5 minutes in unstable patients, during reassessment. Every 15 minutes in stable patients, during reassessment. The student will describe the contraindications for the equipment/procedure. None. The student will describe the possible side effects to the use of the equipment/procedure. None. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Locate the patient's chest/torso. Visually observe chest rise and fall. Place a hand on the chest to count the rise and fall. Use a stethoscope to auscultate breathing. Identify the following: rate, depth, and quality. Rate, count the number of breaths in 30 seconds and multiply by 2. Depth, normal, shallow, deep. Quality, normal, labored, noisy, irregular, Kussmaul, Cheney-Stokes. Vital signs, lung sounds. The student will describe the therapeutic effects of the equipment/procedure. Assess patient's lung sounds. The student will describe the indications for the equipment/procedure. All patients. The student will describe the contraindications for the equipment/procedure. None. The student will describe the possible side effects to the use of the equipment/procedure. None. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Explains the procedure to the patient and remind the patient not to move or talk without instruction. Expose the patient's torso and back or place the stethoscope under clothing. Place the bell on the patient's chest or back and auscultate both inspiratory and expiratory sounds. Primary assessment. Move the stethoscope across and down the anterior chest at the following 4 positions. Right and left apexes at the second intercostal space/mid-clavicular line. Right and left bases at the 4th or 5th intercostal space/mid-clavicular line. Secondary assessment. Move the stethoscope across the lateral chest to include the following 2 positions. Right and left mid-axillary line at the 4th or 5th intercostal space on the lateral aspect of the chest. Right and left mid-axillary line at the 4th or 5th intercostal space on the lateral aspect of the chest. Right and left mid-axillary line at the 4th or 5th intercostal space on the lateral aspect of the chest. Correctly identify the following respiratory deficiencies or abnormal sounds: wheezes, rales, rhonchi. Wheezes, high-pitched, whistling sounds heard during exhalation such as in asthma, due to constriction or swelling. Rales, crackles air trying to pass through fluid in the alveoli, producing a crackling or bubbling sound. Rhonchi, lower-pitched, snoring or rattling sounds caused by secretions or mucus in the larger airways. Vital signs: blood pressure. The student will describe the therapeutic effects of the equipment/procedure. Assess patient's blood pressure. The student will describe the indications for the equipment/procedure. All patients over age 3. Every 5 minutes for unstable patients. Every 15 minutes for stable patients. The student will describe the contraindications for the equipment/procedure. Examine the extremity for ports, dialysis shunts, central lines, mastectomy or injury to the arm. If present, use the other arm. The student will describe the possible side effects to the use of the equipment/procedure. None. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Explains the procedure to the patient and remind them not to move without instruction. Blood pressure via auscultation. Choose the appropriate size cuff. Apply the cuff with the lower end of the cuff positioned one above the antecubital space, elbow. The cuff should cover 2/3 of the upper arm. Locate and palpate the brachial pulse. Position the stethoscope over the brachial artery within the antecubital space where the pulse was palpated. Inflate the cuff approximate 30 mm/Hg above where the brachial pulse can no longer be heard. Slowly open the valve until air steadily escapes from the cuff and the needle slowly drops at a rate of 2-3 mm/Hg per second. As the pressure falls, observe the gauge and note where the needle is at the first sound or pulsation, systolic pressure. As the pressure continues to fall, observe and note the point where the needle is when sounds or pulsations are no longer audible, diastolic pressure, EX 120/80. As soon as the pulse sound stops, open the valve completely and release the remaining air. Record readings in even numbers. Blood pressure by palpation. Choose the appropriate size cuff. Apply the cuff with the lower end of the cuff positioned one above the antecubital space, elbow. Locate and palpate the radial pulse. Inflate the cuff approximate 30 mm/Hg above where the radial pulse can no longer be felt, then deflate the cuff slowly. When the radial pulse becomes palpable, the gauge reading is noted, systolic pressure, EX 120/P. Vital signs, pulse oximetry. The student will describe the therapeutic effects of the equipment/procedure. Used to monitor oxygen saturation of hemoglobin in patients. The student will describe the indications for the equipment/procedure. All patients. The student will describe the contraindications for the equipment/procedure. None. Pulse oximetry readings may be inaccurate for the following reasons: carbon monoxide poisoning, false high. Patients with high obtension, hypovolemia, hypothermia, or anemia. Patients with excessive movement EX seizures. Patients with poor distal circulation. Patients wearing nail polish or acrylic nails. The student will describe the possible side effects to the use of the equipment/procedure. None. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Explains the procedure to the patient. If necessary, clean the patient's finger. Place the probe on any appropriate places using proper orientation: finger, toe, earlobe, across the bridge of nose. Infants use the toe or distal foot. Palpate the radial pulse to ensure that it correlates with the lead display rate and also to check regularity and quality. Record readings and watch for trend comparison. The student will identify the following probable oxygen statuses based on SP02 readings. Normal SP02 equals 97-100%. Hypoxia equals 96%. Severe hypoxia equals 90%. Vital signs: blood glucose. The student will describe the therapeutic effects of the equipment/procedure used to monitor a patient's blood glucose level. The student will describe the indications for the equipment/procedure. All patients who are unresponsive or showing signs of altered mentation should be taken with vitals on patients who have a history of diabetes. The student will describe the contraindications for the equipment/procedure. None. Blood glucose readings may be inaccurate for the following reasons. If a blood source other than capillaries is used, expired test strips are utilized, poorly calibrated device, site not cleared of alcohol with a 4x4, or not allowed to dry prior to obtaining sample. The student will describe the possible side effects to the use of the equipment/procedure. Possible infection if aseptic technique is not utilized. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Explains procedure to the patient, gain consent if patient is conscious and not altered. Prepare the glucometer and equipment, verbalize checking calibration/expiration. Let the patient's arm hang down at their side if possible to allow blood to flow to the fingers. Prep the patient's finger by cleaning the site with an alcohol pad. Place the lancet against the lateral aspect of the finger and engage the lancet. Immediately place the lancet into an approved sharps container. Remove a test strip for the container and insert it into the glucometer. Grasp the patient's finger near the site, squeezing gently to place blood on the test strip. Wait for the glucometer to display the blood glucose value prior to removing the strip. Once the blood glucose value is obtained, remove the test strip and dispose of it properly. Place a band-aid over the site to prevent infection. Record the glucose findings and determine the need for treatment. Monitor and re-evaluate the patient as needed. The student will properly identify the following glucose levels. Normal blood glucose equals 60-120 mg/dl. Hypoglycemia equals 60 mg/dl. Hyperglycemia equals greater than 120 mg/dl. Vital signs: patient assessment. Scene size up. Park vehicle in a safe and convenient location / ensure scene safety. Takes/verbalizes standard precautions. Determine the mechanism of injury, MOI, or nature of illness, NOI, scene clues, or bystanders. Determine number and location of patients. Consider the need for additional or specialized resources. Primary assessment. Form a general impression of the patient upon approach, gain consent, and treat any obvious life threats, gross hemorrhage. Form a general impression of the patient upon approach, gain consent, and treat any obvious life threats, gross hemorrhage. Consider C-spine on all patients. Stabilize C-spine if necessary. Assess patient's level of consciousness, AVPU, identify the patient's chief complaint. Assess airway open and patent. If not, stop and open it, remove obstructions, suction if necessary. Assess breathing, look, listen, feel. Auscultate breath sounds and determine if breath sounds are equal and present bilaterally. Rate, normal, fast, slow. Depth, normal, shallow, deep. Quality, normal, labored, noisy. Provide 0-2 therapy as needed. Assess circulation. Rate, normal, fast, slow. Rhythm, regular or irregular. Quality, normal, thready, bounding. Skin, color, temperature, condition, capillary refill in children. Based on primary assessment, determine patient priorities: stable or unstable. Determine transport decision: rapid transport, unstable/load and go, or continue on scene assessment, stable, based on MOI or initial assessment. Significant MOI, or if patient fails primary assessment, equals conduct a rapid complete secondary assessment, 60 to 90 seconds. Non-significant MOI or stable medical PT equals conduct a focused history and modified secondary assessment. History taking may be done simultaneously with other tasks. Sample history. UPCRST, for chest discomfort, shortness of breath and nausea. Identify pertinent negatives. Secondary assessment may not be completed in critical patients with life threats. Vital signs: skin, pupils, respirations, pulse, B/P, lung sounds, pulse oximetry, blood glucose, pupils. Reassessment: chief complaint, ongoing vitals, interventions, patient changes. Unstable every 5 minutes. Stable every 15 minutes. After any treatments or if there is a change in the patient's status. Record findings, treatments, and patient's changes. 2.08 Basic Airway, Oxygen Administration. The student will describe the therapeutic effects of the procedure/equipment. To provide supplemental oxygen therapy to diminish respiratory distress and tissue/organ hypoxia. The student will describe the indications of the equipment/procedure. 1. To meet the increased oxygen demand for any injured or ill patients. 2. Any situation or condition in which hypoxia or hypoxemia is suspected. The student will describe the contraindications of the equipment/procedures. 1. None, if the patient is showing signs of hypoxia. The student will describe the possible side effects to the use of the equipment/procedure. 1. May result in respiratory depression or arrest in patients breathing on hypoxia drive. 2. Oxygen toxicity may result after several days of 50% oxygen concentration delivery. Oxygen safety precautions. Cylinders that are positioned upright must be secured to prevent tipping or falling over. Do not seal or cover the valve stem with tape or petroleum-based substances, it can contaminate the 0-2. 3. Do not allow smoking in the vicinity when oxygen is in use. 4. Do not use regulators with missing or modified pins. 5. Keep all valves closed when not in use, even when the tank is empty. 6. Keep oxygen cylinders horizontal and secured from rolling. The student will demonstrate the use of the equipment/procedure. 1. Takes/verbalizes standard precautions. 2. Visually inspects oxygen regulator and bottle, pins, O-ring, hydrodate, damage. 3. Quickly open, then shut, the cylinder valve for 1 second to remove any dust or debris. 4. Properly attaches the regulator to the tank, open valve, and check regulator for leaks. 5. Verify adequate tank pressure. 6. Attach a nasal cannula and set the proper flow rate, 1-6 lpm, 24%-44%. 7. Attach a non-rebreather and set the proper flow rate, 10-15 lpm, max 90%. 8. Attach a bag valve mask, BVM, and set the proper flow rate, 15-25 lpm, 97-100%. 2.09 Basic Airway Skills. 2.09 Basic Airway Skills. 2.09 Basic Airway Skills. Oropharyngeal airway, OPA. The student will describe the therapeutic effects of the equipment/procedure. Improves airway patency. The student will describe the indication for the equipment/procedure. Any unconscious patient without gag reflex. The student will describe the contraindications for the equipment/procedure. Patients with an intact gag reflex. The student will describe the possible side effects to the use of the equipment/procedure. Partial or complete obstruction of the airway, usually from improper sizing. Localized soft tissue, mucosal or dental damage. Retching/vomiting caused by an intact gag reflex. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Maintain manual C-spine immobilization throughout the procedure, if C-spine injury is suspected. Select an appropriate size oropharyngeal airway measure from the corner of the mouth to the earlobe or the corner of the mouth to the angle of the jaw. Primary method: open the patient's mouth using the cross-finger technique. Insert tip toward the roof of mouth, rotate 180* when the tip reaches the soft palate. The airway can also be inserted sideways in the corner of the mouth and rotated 90* and advanced into place. The flange should rest against the patient's teeth, with the other end opening into the pharynx. Alternate method: tongue depressor or bite stick, preferred in pediatrics. Insert the tongue depressor into the mouth until the tip is at the base of the tongue. The tongue is then pressed down towards the mandible and forward with the tongue depressor. The airway is then inserted in its normal anatomical position, resting against the teeth. If the patient begins to retch or gag, remove the device immediately. Assess airway patency looking for improvements in chest rise, lung sounds and pulse oximetry. 2.10 Basic Airway. 2.10 Basic Airway. Nasopharyngeal airway, NPA. The student will describe the therapeutic effects of the equipment. Improve airway patency. The student will describe the indications for the equipment/procedure. Any unconscious or semi-conscious patient with an intact gag reflex or clenched teeth, trismus. The student will describe the contraindications of the equipment/procedure. Basilar skull fracture, periorbital and/or nasal fractures or any suspected head trauma. The students will describe the possible side effects of the use of the equipment/procedure. Obstruction of the airway, usually from improper sizing. Localized soft tissue, mucosal damage, or bleeding. Intracranial insertion following significant head trauma. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Maintain manual C-spine immobilization throughout the procedure if C-spine injury is suspected. Determine the patient's larger nair. Select and measure the appropriate size nasopharyngeal airway measure from the tip of the nose to the earlobe or to the angle of the jaw. Lubricate with a water-soluble gel. For the right nair insert, bevel towards the septum. For the left nair insert, bevel towards the septum and gently rotate 180* during insertion. If resistance is met during insertion, rotate gently from side to side. If the NPA still will not advance, attempt the other side. Continue to insert until the flange rests against the nostril. Assess airway patency looking for improvements in chest rise, lung sounds and pulse oximetry. 2.11 Basic Airway, oral suctioning. The student will describe the therapeutic effects of the equipment/procedure. To remove mucus, vomitous secretions, blood and sputum from the hypopharynx. The student will describe the indications for the equipment/procedure. Any patient's airway or breathing that is compromised by fluid. The student will describe the contraindications for the equipment/procedure. None. The students will describe the possible side effects to the use of the equipment/procedure. Hypoxia. Reflex bradycardia. Injury to the oropharyngeal tissue, soft tissue, mucosal or dental damage. Vomiting. The student will demonstrate the use of the equipment/procedure. Takes/verbalized standard precautions. Test/set the unit to confirm a vacuum reading greater than 300 mm/Hg. Select and measure the appropriate size suction catheter. Measure from the corner of the mouth to the earlobe or angle of the jaw. Rigid tip aka yang cower or tonsil tip, soft catheter aka French catheter. Open the patient's mouth using the cross-finger technique. Insert the suction catheter to the measured depth in the pharynx and then cover the hole on the suction catheter to create suction. Suction the pharynx and hypopharyngeal area from side to side as you withdraw the catheter. Suction for no longer than adults 15 seconds. Children 5 seconds. Infants 5 seconds. Reoxygenate the patient for at least 30 seconds and reassess the need for additional suctioning. 2.12 Basic Airway, Bag Valve Mask, BVM. The student will describe the therapeutic effects of the equipment/procedure. Manually operated ventilation device that achieves approximately 100% oxygen delivery. The student will describe the indications for the equipment/procedure. Any patient that requires ventilation assistance affecting rate or depth. Patients with pulmonary edema, RALS. The student will describe the contraindications for the equipment/procedure. None. The student will describe the possible side effects to the use of the equipment/procedure. Can result in gastric distension, especially in children. Inconsistent or inadequate tidal volumes. Insufficient face seal can result in poor ventilation or oxygenation. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. If the patient is unresponsive, open the airway using the appropriate technique, head tilt, jaw thrust. Check the airway for foreign bodies/fluids, insert an airway adjunct when possible. Select the appropriate size bag valve mask. Apply the mask with the apex of the bridge of the patient's nose and align the base between the lower lip and chin. Achieve a proper mask seal using an approved method, OK, EC, C3, by placing the thumb over the top portion of the mask and bringing the lower jaw up to the mask with the last 3 fingers. Compress the bag smoothly, delivering adequate volume over a 1-second period at a rate of, adults, 10-12 breaths/min 1 every 5 to 6 SECS. Pediatrics 12-20 breaths/min 1 every 3 to 5 SECS. Connect the BVM to an oxygen source if not already done and set the proper flow rate, 15 to 25 LPM. Successfully ventilate the mannequin 10 times. Look for signs of adequate ventilations. Observe patient's chest rise and fall. Heart rate returns to normal. Skin color/temperature/moisture improve. Improvement in pulse oximetry. 2.13 Basic Airway, King Airway. The student will describe the therapeutic effects of the equipment/procedures. 1. To establish a patent and protected airway. The student will describe the indication for equipment/procedures. 1. Any unresponsive patient without a gag reflex and not likely to regain consciousness. The student will describe the contraindications of the equipment/procedures. 1. Patients with an intact gag reflex. 2. Patients with esophageal disease or varices. 3. Patients who have ingested a caustic substance, bleach, acid, etc. The student will describe the possible side effects to the use of the equipment/procedures. 1. Stimulation of the gag reflex and vomiting. 2. Soft tissue trauma. The student will demonstrate the use of the equipment/procedures. 1. Takes/verbalizes standard precautions. 2. Identify, select, and prepare the correct size tube based on patient's height. Size 3, yellow, 4'5" in height, 45 to 60 ml of inflation. Size 4, red, 5'6" in height, 60-80 ml of inflation. C size 5, purple, 6 in height, 70-90 ml of inflation. 3. Open the airway and check for fluids or obstructions, suction if needed. 4. Ventilate with 100% O2 and insert an OPA. 5. Test cuff inflation system by injecting the minimum recommended volume of air into the cuff. 6. Remove all air from the cuffs prior to insertion. 7. Apply a water-based lubricant to the beveled distal tip and posterior aspect of the tube. 8. Position the head and remove the OPA. Sniffing position is ideal, it may be inserted with the head in the neutral position. 9. Hold the device at the connector with the dominant hand. With the non-dominant hand, hold mouth open and apply chin-tongue lift, unless contraindicated by C-spine. Precautions. 10. Holding the device at a 45-90* angle with the blue orientation line touching the corner of the mouth, introduce the tip into the mouth and advance behind the base of the tongue. 11. As the tube tip passes the base of the tongue, rotate the tube back to midline with the blue line facing the chin. 12. Without exerting excessive force, advance the king LTSD until the proximal opening of the gastric access lumen is aligned with the teeth or gums. 13. Inflate both air cuffs with the proper amount of air. While ventilating the patient to assess placement, you may need to simultaneously withdraw, adjust, the airway until ventilation is easy and free-flowing. Confirm proper position by auscultation of absence of epigastric sounds, present lung sounds and chest rise. 16. Secure the device using a tube holder or tape without covering the proximal opening of the gastric lumen and record the depth. 3.14 CPR/AED, adult/child. The 2016 AHA BLS Provider Manual shall supersede this skill sheet. The student will describe the therapeutic effects of the equipment/procedures. Maintain blood circulation to the brain and heart, CPR. Restore cardiac function to patients VFib/VTach through defibrillation, AED. The student will describe the indications for the equipment/procedures. Adult, patients who are unresponsive, apneic/gasping respirations and pulseless. Children, patients who are unresponsive, apneic/gasping respirations, pulseless or have a heart rate less than 60 bpm after 30-60 SEC of oxygenation. The students will describe the contraindications for the equipment/procedures. Patients with a pulse, except as noted above for children. Cardiac arrest secondary to massive trauma, exception, drownings and electrocutions. The student describe the possible side effect of the equipment/procedures. Possible broken ribs/sternum due to chest compressions. Possible vomiting due to gastric inflation, ventilating too fast or too forcefully. Defibrillating the patient while in water, on metal, or in contact with the patient can cause injury. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. General impression of the patient, ask bystanders as you approach about possible downtime and CPR. Check for unresponsiveness, within 10 seconds of being on scene. Briefly check for no breathing or only gasping. Call for help and get an AED and call for ALS backup. Expose the patient's torso. Circulation, check for a carotid pulse, no greater than 10 seconds. Adult, if no pulse, start chest compressions. Children, if no pulse, start chest compressions. If pulse is less than 60 bpm with signs of poor perfusion, ventilate 30-60 SECS. If pulse does not improve, begin chest compressions. Preform high-quality CPR, per AHA standards CAB. Adult/children 30:2, 5 cycles equals 2 minutes, child, 2 rescuer 15:2 10 cycles. Hand placement, between the nipple line, 1 hand for a small child. Adequate rate, at least 100-120/minute, 30 compression in less than 18 SECS. Adequate depth, compress at least 2 inches. Allows complete chest recoil. Minimizes interruptions, gives 2 breaths in less than 10 seconds. Switches compressors every 5 cycles/2 minutes. Attempt to administer 2 ventilations. When time allows, size and apply an airway adjunct, OPA, NPA, or King airway. After the AED arrives, position it next to the patient on the same side as rescuer and turn it on. Apply AED pads, remove hair and / or medication patches, do not place pads on top of pacemaker. Clear patients and allow AED to analyze. If AED indicates a shockable rhythm, shock advised. Clear the victim and deliver shock. Resume high-quality CPR, switch rescuers every 2 minutes/5 cycles. If AED indicates a rhythm that is not shockable, no shock advised. No signs of life, no breathing or movement, resume CPR. Signs of life, check for a pulse, assess breathing and continue with ventilations if necessary, allow AED to reanalyze every 2 minutes. 3.15 CPR, infant. The 2016 AHA BLS Provider Manual shall supersede this skill sheet. The student will describe the therapeutic effects of the equipment/procedures. Maintain blood circulation to the brain and heart, CPR. The student will describe the indication for the equipment/procedures. Infant patients who are unresponsive, apneic/gasping respirations, pulseless or have a heart rate less than 60 bpm after 30-60 SEC of oxygenation. The student will describe the contraindications of the equipment/procedure. Patients with heart rates 60. Cardiac arrest secondary to massive trauma, exception drownings and electrocutions. The student describe the possible side effects to the use of the equipment/procedure. Possible broken ribs due to CPR. Possible vomiting due to gastric inflation, ventilating too fast or too forcefully. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. General impression of the patient, ask bystanders as you approach about downtime and CPR. Check for unresponsiveness, within 10 seconds of being on scene. Briefly check for no breathing or only gasping. Call for help and call for ALS backup. If alone, remain with the infant and perform 2 minutes of CPR if too prior to leaving to call for help. Expose the patient's torso. Circulation, check for a brachial pulse, no greater than 10 seconds. If no pulse, place infant on a hard flat surface, start chest compressions. If pulse is less than 60 bpm with signs of poor perfusion, ventilate 30-60 seconds. If pulse does not improve, place infant on hard flat surface and begin chest compressions. 30:2 ratio. Perform high quality CPR. Hand placement. 1 rescuer, 2 fingers just below the nipple line, 30:2. 2 rescuers, 2 thumbs encircling hands, just below the nipple line, 15:2. Adequate rate, at least 100-120/min, 30 compressions in less than 18 SECS. Adequate depth, 1 1/2 inches, at least 1/3 the depth of the body. Allows complete chest recoil. Minimizes interruptions, give 2 breaths in less than 10 seconds. Switch compressors, every 2 minutes. When time allows, size and apply an airway adjunct, OPA or NPA. Appropriate ratio for age and number of rescuers. 1 rescuer, 30:2. 2 rescuer, 15:2. Provide effective breaths. Adequately opens patient's airway. Delivers each breath over 1 second. Produces visible chest rise, avoids excessive ventilation. 3.16 FBAO, Adult. Foreign body airway obstruction. The 2016 AHA BLS Provider Manual shall supersede this skill sheet. The student will describe the therapeutic effects of the equipment/procedures. To provide a patent airway for patient oxygenation. The student will describe the indications for the equipment/procedures. Patients with a FBAO who are unable to forcefully cough or speak. The students will describe the contraindications for the equipment/procedures. Patients who are able to forcefully cough or speak. The student will describe the possible side effects to the use of the equipment/procedure. None. The student will demonstrate the use of the equipment/procedure. Conscious patient. Takes/verbalizes standard precautions. General impression, looking for the universal sign of choking. Ask the patient if they are choking/ask if you may help. Stand or kneel behind the victim and wrap your arms around the victim's waist. Make a fist with one hand. Place the thumb side of your fist against the victim's abdomen, midline, slightly above the navel and well below the breastbone. If the patient is pregnant or obese, perform chest thrust. Fist location is between the nipple line and straight back, instead of abdominal thrust. Grasp your fist with your other hand and press your fist into the victim's abdomen with quick forceful upward thrust. Give each new thrust with a separate, distinct movement to relieve the obstruction. Repeat thrust, until the object is relieved from the airway or the patient becomes unresponsive. Unconscious patient or patient becomes unconscious. Activate the emergency response system/call for ALS help. Lower the victim to the ground. Expose the patient's torso. Find the proper hand placement, between the nipple line. Begin CPR, with chest compressions, 30 compressions. When opening the airway to give ventilations, look for the object. If the object is visualized, remove it with your fingers. Give a breath and look for chest rise. If no chest rise, reposition the head and attempt to reventilate, looking for chest rise. Reassess respirations/provide oxygen. 3.17 FBAO, Infant. Foreign body airway obstruction. The 2016 AHA BLS Provider Manual shall supersede this skill sheet. The student will describe the therapeutic effects of the equipment/procedure. To provide a patent airway for patient oxygenation. The student will describe the indication for the equipment/procedure. Patients with a FBAO who are unable to make sounds or breathe. The student will describe the contraindications for the equipment/procedure. Patients who are able to cough or breathe adequately. The student will describe the possible side effects to the use of the equipment/procedure. None. The student will demonstrate the use of the equipment/procedure. Conscious patient. Takes/verbalizes standard precautions. Kneel or sit with the infant in your lap. Expose the chest, if clothing is easily removed. Hold the infant face down, with the head slightly lower than the chest, resting on your forearm. Support the infant's head and jaw with your hand. Do not compress the soft tissue of the throat or cover the infant's mouth with your fingers. Deliver 5 back slaps, forcefully between the infant's shoulder blades, using the heel of your hand. Place your free hand on the infant's back, supporting the head with the palm of your hand and turn the infant over as a unit, between your forearms. Keeping the head below the trunk. Provide 5 quick downward chest thrust, in the middle of the chest, over the lower half of the breastbone, same position as CPR. Deliver about 1 per second. Repeat steps DG until the object is expelled from the airway or the victim becomes unresponsive. Unconscious patient or patient becomes unconscious. Activate the emergency response system / call for ALS help. Begin CPR, with chest compressions 30:2. When opening the airway to give ventilations, look for the object. If the object is visualized, remove it with your fingers. Reassess respirations / provide oxygen. 4.18 Medication, nitroglycerin administration, NTG. 4.18 Medication, nitroglycerin administration, NTG. The student will describe the therapeutic effect of the equipment / procedure. Dilates blood vessels, increases blood flow to the heart. Decreases workload of the heart. The student will describe the indications of the equipment / procedure. Patients who exhibit signs and symptoms of chest pain. The medication is prescribed for this patient. Medical direction authorizes use, on or offline. The student will describe the contraindications for the equipment / procedure. Patient's systolic blood pressure is below 90 mm/Hg or a 30 mm/Hg drop from baseline. The heart rate is less than 50 bpm or greater than 100 bpm. Ingestion of sexually enhancing drugs within the past 24 hours, Viagra, Cialis, Levitra. The patient has a suspected head injury. The patient has already taken a total of 3 doses prior to arrival. The student will describe the possible side effects of the equipment / procedure. Headache. Drop in blood pressure with an increase in heart rate to compensate. The student will demonstrate the use of the equipment / procedure. Takes / verbalizes standard precautions. Perform a primary assessment, LOC, C/C, ABCs, expose, rapid scan, determine TXP decision. Investigate patient's chief complaint. Must obtain / record sample and UPCRIST. Obtain / record a complete set of baseline vitals HR, B/P, RR, skin, pupils, SpO2. Perform a focused physical exam, DCAPBLS TIC, on area, based on chief complaint. Determine that the patient has their own nitroglycerin and protocols allow administration. Check 6 rights: right, patient, medication, route, dose, date, documentation. Confirm blood pressure is 90 mm/Hg systolic. Confirm the patient's level of consciousness, must be alert and oriented. Confirm the PTS heart rate is greater than 50 and less than 100 bpm. Confirm that the patient has not taken any sexual enhancing drugs within the last 24 hours. Confirm dose of NTG, 0.30 or 0.4 mg tablet or sublingual spray. Determine if the patient has taken any nitro prior to arrival. Prime the sprayer by doing a test spray into the air. Avoid spraying into the eyes. Assist patient placing 1 tablet or delivering 1 metered dose spray under the tongue. Instruct patient to close mouth and not to swallow. After 5 minutes reassess / record patient's medical condition and vital signs. If pain persists, continue with NTG administration according to protocol up to 3 doses. Document medication, dose, action, route, time, DART, and patient's response, +/. Monitor patient's condition. If condition worsens, continue oxygenation, obtain medical direction, on/offline, for additional nitroglycerin dosages. If condition improves, continue oxygenation, monitoring vitals, and transport. 4.19 Medication, epinephrine administration, EPIPEN. 4.19 Medication, epinephrine administration, EPIPEN. The student will describe the therapeutic effects of the equipment/procedure. Relieves severe allergic reactions. Constricts blood vessels and dilates bronchioles. The student will describe the indication for the equipment/procedure. Patients exhibiting S/S of a severe allergic reaction, urticaria, respiratory distress, hypotension. Medication is prescribed for this patient. Medical direction authorizes use, on or offline. The student will describe the contraindication for the equipment/procedure. No contraindications were used in a life-threatening situation. The student will describe the possible side effects to the use of the equipment/procedure. Tachycardia and excitability. Chest pain and/or headache. Dizziness and/or pallor. Nausea and/or vomiting. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Perform a primary assessment, LOC, C/C, ABCs, expose, rapid scan, determine TXP decision. Investigate patient's chief complaint. Must obtain/record sample and ASPIRIN. Obtain/record a complete set of baseline vitals, HR, B/P, RR, skin, pupils, SpO2. Perform a focused physical exam, DCAPBLS-TIC, on area, based on chief complaint. Determine that the patient has their own auto-injector and protocols allow administration. Check 6 right, patient, medication, route, dose, date, documentation. Confirm dosage of EPINEPHRIne, Pedi 0.15 mg, adult 0.3 mg. Explain the procedure to the patient and instruct them not to move without instruction. Remove the safety cap from the auto-injector and hold it at a 90° angle to the lateral thigh. Place the tip of the auto-injector against the patient's thigh, laterally, midway between the hip and the knee. Push the auto-injector firmly until the injector activates, holding firmly until it discharges completely, at least 10 seconds. Discard the auto-injector into a sharps container. Critical failure. After 5 minutes, reassess patient's medical condition and vital signs. Document medication, dose, action, route, time, DART, and patient's response, +/. Monitor patient's condition. If condition worsens, continue oxygenation, obtain medical direction, on/offline, for additional epinephrine dosages. If condition improves, continue oxygenation, monitoring vitals, and transport. 4.20 Medication, baby aspirin. The student will describe the therapeutic effects of the equipment/procedure. Helps to inhibit clot formation in relationship to myocardial infarctions and strokes. The student will describe the indication for the equipment/procedure. Chest discomfort that is associated with myocardial infarctions. Medical direction authorizes use, on or offline. The student will describe the contraindication for the equipment/procedure. Hypersensitivity, allergic, to aspirin. Active ulcers or other bleeding disorders. If the patient has taken aspirin prior to arrival. Pregnant patients. Patients experiencing an asthma attack. The student will describe the possible side effects to the use of the equipment/procedure. Nausea. Gastrointestinal bleeding. Exacerbation, worsening, of asthma. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Perform a primary assessment, LOC, C/C, ABCs, expose, rapid scan, determine TXP decision. Investigate patient's chief complaint. Must obtain/record sample and ASPIRIN. Obtain/record a complete set of baseline vitals, HR, B/P, RR, skin, pupils, SpO2. Perform a focused physical exam, DCA-PBLS tick, on area, based on chief complaint. Determine protocols allow administration. Check 6 rights right, patient, medication, route, dose, date, documentation. Confirm the patient's level of consciousness, must be alert and oriented. Confirm that the patient has not taken any aspirin prior to EM's arrival. Confirm dose of baby aspirin, 2, 81 mg each, given orally. Assist patient giving them 2 chewable baby aspirin. Reassess/record patients, medical condition and vital signs. Document medication, dose action route time, DART, and patient's response, +/. Monitor patient's condition. If condition worsens, continue oxygenation, obtain medical direction, on/offline, for an additional aspirin dose. If condition improves, continue oxygenation, monitoring vitals, and transport. 4.21 Medication, metered dose inhaler, MDI. 4.21 Medication, metered dose inhaler, MDI. The student will describe the therapeutic effects of the equipment/procedure. Provide breathing relief for patients with asthma experiencing difficulty breathing. The student will describe the indication for the equipment/procedure. Patients experiencing asthma attacks and/or bronchospasm associated with emphysema and chronic bronchitis. The medication is prescribed for this patient. Medical direction authorizes use, on or offline. The student will describe the contraindication for the equipment/procedure. None. The student will describe the possible side effects to the use of the equipment/procedure. Tachycardia. Do not puncture container. Do not expose to temperature greater than 120 as canister may burst. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Perform a primary assessment, LOC, C/C, ABCs, expose, rapid scan, determine TXP decision. Investigate patient's chief complaint. Must obtain/record sample and UPCRIST. Obtain/record a complete set of baseline vitals, HR, B/P, RR, skin, pupils, SpO2. Perform a focused physical exam, DCA-PBLS tick, on area, based on chief complaint. Determine that the patient has their own multi-dose inhaler, MDI, and protocols allow administration. Check 6 rights right, patient, medication, route, dose, date, documentation. Shake the inhaler well, remove the cap from the mouthpiece, check mouthpiece for foreign objects and remove them if present. Ensure that the canister is fully and firmly inserted into the plastic mouthpiece. Prime the sprayer by doing a test spray into the air. Avoid spraying into the eyes. Hold the inhaler upright and insert the mouthpiece into the patient's mouth. Instruct them to seal their lips tightly over the mouthpiece. Have the patient breathe in slowly through their mouth, and press down on the inhaler once. Remove the inhaler and have the patient hold their breath for 10 seconds. Instruct them to exhale slowly. If orders are for 2 puffs, wait 1-2 minutes and shake inhaler again before giving second puff. Reassess/record patients, medical condition and vital signs. Document medication, dose action route time, DART, and patient's response, +/. Monitor patient's condition. If condition worsens, continue oxygenation, obtain medical direction, on/offline, for additional multi-dose inhaler dose. If condition improves, continue oxygenation, monitoring vitals, and transport. 4.22 Oral glucose. The student will describe the therapeutic effects of the equipment/procedure. Raise blood glucose levels. The student will describe the indication for the equipment/procedure. Altered mental status. History of diabetes controlled by medication or blood glucose level less 60 mg/dl. The ability to swallow the medication. The student will describe the contraindication for the equipment/procedure. Unresponsive patient or cannot swallow the medication. Confirm blood glucose is greater than 60 mg/dl. The student will describe the possible side effects to the use of the equipment/procedure. Airway obstruction. Aspiration. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Perform a primary assessment, LOC, C/C, ABCs, expose, determine transport decision. Investigate patient's chief complaint. Must obtain/record sample and UPCRIST. Obtain/record a baseline vital signs, BP, HR, RR, glucose, pupils, skin, SpO2. Perform a focused physical exam, DCA-PBLS-TIC, on area, based on chief complaint. Confirm protocols allow administration. Check 6 rights: right, patient, medication, route, dose, date, documentation. Ensure signs and symptoms are consistent with hypoglycemia. Ensure blood glucose is less than 60 mg/dl. Ensure patient can swallow. Hold back patient's cheek and squeeze glucose into the patient's mouth between the cheek and gum. Patient may also self-administer this way or squeeze glucose on a tongue depressor and deposit between the cheek and gum. Reassess mental status. Improvement may take up to 20 minutes. Reassess blood glucose. Reassess/record patient's vital signs. Document medication, dose, action, route, time, DART, and patient's response, +/. Monitor patient's condition. If condition worsens, continue oxygenation, obtain medical direction, on/offline, for additional glucose dose. If condition improves, continue oxygenation, monitoring vitals, and transport. 5.23 Trauma, bleeding control/shock management. The student will describe the therapeutic effect of the equipment/procedure. Control hemorrhage. Prevent wound contamination. The student will describe the indication for the equipment/procedure. Any open injury that is actively bleeding. The student will describe the contraindications to the use of the equipment/procedure. None, if bleeding is life-threatening. The student will describe the side effect to the use of the equipment/procedure. Possible additional contamination. The student will demonstrate the use of the equipment. Takes/verbalizes standard precautions. Explains the procedure to the patient and visualizes the wound. Apply and maintain direct pressure using a gloved hand first, then a sterile dressing and bandage. Do not bandage a dressing in place until bleeding has stopped. If bleeding persists, apply a pressure dressings over the dressing already in place and wrap with bandage tight enough to control bleeding. Never remove dressings already in place. Monitor patient for reoccurring hemorrhage. If bleeding is controlled, assess pulse, motor, and sensation, PMS, of the affected extremity and treat for shock. If unable to control hemorrhage, use a tourniquet. 5.24 Trauma, tourniquet. The student will describe the therapeutic effects of the equipment/procedure. To control hemorrhage. Prevent wound contamination. The student will describe the indication of the equipment/procedure. Any bleeding that is not controlled by direct pressure or dressings. The student will describe the contraindication of the equipment/procedure. None if the bleeding is life-threatening. The student will describe the possible side effects to the use of the equipment/procedure. Possible additional contamination. The student will demonstrate the use of the equipment. Takes/verbalizes standard precautions. If unable to control hemorrhage, use a tourniquet. Apply a tourniquet, commercial device, CAT tourniquet, MAT tourniquet, RATS tourniquet, or a multi-layer bandage such as a triangular bandage at least 4 wide. Apply at least 2 proximal to the wound high and tight. Never apply over a joint. Never use wire or rope. Tourniquets that are made from a triangular bandage need to be 4 wide. Wrap once around the limb. Tie a knot in the bandage. Place a stick/rod over the knot. Tie another knot over the stick/rod. Use the stick/rod as a handle, windlass, and twist until bleeding stops. Secure in place by looping each end of the bandage once around the ends of the stick/rod. Wrap the bandage back around the limb once. Tie a knot on top of the stick/rod. Combat application tourniquet, CAT. Wrap the band around the limb. Pass the tip through the inside slit on the buckle. Pull tight. Pass the tip through the outside slit on the buckle. Twist the rod until bleeding stops. Place the rod inside the clip and secure with the white strap. Document the time applied either on the tourniquet or patient's forehead, TK00:00. Maintain the tourniquet in open view and monitor for recurrent hemorrhage. Never remove a tourniquet in the field. Treat for shock if necessary. Ensure high-flow oxygen is applied and prevent body heat loss. Notify hospital personnel that a tourniquet was applied. 5.25 Trauma, spinal immobilization backboard. Supine patient. The student will describe the therapeutic effects of the equipment/procedure. To provide immobilization of suspected neck and back injuries. To provide full body support for CPR, patient movement, or splinting of fractures. The student will describe the indication for the equipment/procedure. Any trauma patient. Any cardiac arrest patient. Any drowning patient. Any patient complaining of neck or back pain resulting from trauma. Any patient complaining of a head injury sufficient enough to suspect C-spine injury. The student will describe the contraindication of the equipment/procedure. Relative, patients with spinal deformities that require alternative packaging. The student will describe the possible side effect of the equipment/procedure. Injury can result from movement necessary to place the patient onto the backboard. The student will demonstrate the use of the equipment. Takes/verbalizes standard precautions. Explains the procedure to the patient and reminds them not to move without instruction. Direct a rescuer to establish manual immobilization of C-spine. Evaluate/record baseline pulse, motor, and sensation, PMS, in all extremities. Perform a neck survey, check for JVD, tracheal deviation, and stair-stepping, and apply a C-collar. Place backboard next to patient, along the affected side if possible. If the patient is standing, place the backboard behind the patient and lower the patient backward onto the board as a single unit. Standing take down, skip steps 7 and 8. Position the top of the backboard approximately 12 above the patient's head. On the head person count log roll the patient and assess the posterior, move the board under the patient and log roll patient onto the backboard. Adjust patient's position on the backboard using the 45* slide. Correctly position and secure the chest straps, using the push/pull method. Straps go over the trapezius, crossing over the chest. Correctly position and secure the pelvis/leg straps, using the push/pull method, straps crossing over pelvis/legs. If patient is unconscious, secure upper extremities in with pelvis strap. Correctly position and secure the ankle strap, using the push/pull method. Secure patient's head to the board in a neutral position. Use padding under the head if necessary. Secure and confirm the straps capture the patient's shoulder and pelvic girdle to prevent movement when turned. Reassess pulse, motor, and sensation, PMS, in all extremities. Monitor patient and record any changes in patient condition. 5.26 Trauma, Spinal Immobilization, KED. Seated patient. The student will describe the therapeutic effects of the equipment/procedure. Immobilize spine for transfer from a seated position to a backboard with minimal movement. The student will describe the indication for the equipment/procedure. Any stable patient found in a seated position where immobilization is required or neck or back pain that requires immobilization to a backboard. The student will describe the contraindications for the equipment/procedure. Any unstable patient. The student will describe the possible side effects to the use of the equipment/procedure. Delay in transport time. Respiratory difficulty due to over-tightening of the chest straps. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Explain the procedure to the patient and remind them not to move without instruction. Direct a rescuer establish manual immobilization of C-spine and place the head in a neutral position. Evaluate/record baseline pulse, motor, and sensation, PMS, in all extremities. Perform a neck survey, check for JVD, tracheal deviation, and stair-stepping and apply a C-collar. Direct a second rescuer to tilt the patient forward as a unit utilizing the C-clamp method. Assess patient's posterior. Carefully slide the KED behind the patient with the smooth side towards the patient. Undo the Velcro leg straps, pull each strap down into the side of the patient. Pull the device upwards, so the sides, wings, of the device are fitted snugly under the armpits. Loosely fasten the middle, yellow, strap using the push/pull method. Loosely fasten the bottom, red, strap using the push/pull method. Loop the leg, black, straps around the same side leg and firmly snug them to the buckles on the same side. Use padding to fill any voids between the patient's head and device, if necessary. Apply and secure the chin and head straps. Ask the patient to breathe deeply and fasten the top, green, strap using the push/pull method. Ensure all straps are secure and now firmly snug prior to extrication. Have patient hold hands together or tie thumb/wrist together. Swivel the patient to facilitate extrication and slide the patient onto the backboard. If the KED has handles on sides, they are used to ease movement. They are not rated for horizontal lifting. Carefully release both leg straps and extend the patient's hips and knees. Consider releasing the top chest strap. Secure the patient to the backboard, leaving the KED attached to the patient. Reassess the patient's pulse, motor, and sensation, PMS, in all extremities. Monitor patient and record any changes in patient condition. 5.27 Trauma, Helmet Removal. The student will describe the therapeutic effects of the equipment/procedure. To remove a helmet without doing any further injury to the spine. The student will describe the indications for the equipment/procedure. The need for manual airway maneuvers or ventilatory assistance. Altered mental status. Patients with bleeding originating from inside the helmet. Patient whose helmet is found to be loose or poorly fitting. With the helmet on, the rescuer is unable to bring the patient's C-spine in line or unable to secure to a backboard. The student will describe the contraindications for the equipment/procedure. None. The student will describe the possible side effects to the use of the equipment/procedure. Improper helmet removal can cause additional injury to the patient. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Explains the procedure to the patient and remind them not to move without instruction. First rescuer holds C-spine by placing their hands on each side of the helmet with the fingers stabilizing the mandible. Second rescuer open the face shield, if present, and assess mental status, ABCs, and removes chin strap. Second rescuer takes over C-spine by placing one hand behind the patient's neck and the other hand on the lower jaw, cupping the mandible with the forefingers and thumb. First, rescuer releases C-spine, gently slips the helmet off the patient's head, stopping when the helmet reaches the halfway point. Second, rescuer slides their hand from the neck to the back of the head to prevent the head from snapping back. First, rescuer removes the helmet the remainder of the way, takes over manual C-spine immobilization. Second, rescuer performs a neck survey, sizes, and applies a C-collar. Secure the patient to the backboard. Monitor the patient and record any changes in patient condition. 5.28 Trauma, splinting, long bone. 5.28 Trauma, splinting, long bone. 5.28 Trauma, splinting, long bone. The student will describe the therapeutic effects of the equipment/procedure. Reduce pain. Prevent further injury. Control hemorrhage. The student will describe the indications of the equipment/procedure. Any suspected fracture or dislocation of an extremity, in a stay-and-play patient. Time permitting or with conditions requiring a load-and-go patient, splinting may be done while en route to the hospital. The student will describe the contraindications for the equipment/procedure. Critical load-and-go patients in which it will delay transport. The student will describe the possible side effects to the use of the equipment/procedure. Possibility of neurovascular injury. The student will demonstrate the use of the equipment/procedure. Takes/verbalize standard precautions. Explain the procedure to the patient and remind them not to move without instruction. Instruct partner to stabilize the injury. Expose the injury. If the injury is below the waist, expose bilaterally, perform DCA/PBLS TIC. Assess/record baseline pulse, motor, sensation, PMS, distal to the injury, control any bleeding if present. If an open wound is present, apply and secure a sterile dressing to the wound. Select the appropriate splint. While providing support, gently lift the injury and apply the splint to the injury and pad any voids if necessary. Splint the fracture in the position found unless the extremity is pulseless, cyanotic, or severely angulated. If any of those are found, attempt to realign it once into a normal anatomical position, using gentle traction. If resistance to limb alignment is felt, splint it in deformed position. Immobilize the extremity in the position of function if possible. When immobilizing a bone, splint joint to joint. Immobilize the joint above and below the fracture. When immobilizing a joint, splint bone to bone, above and below the joint. If possible, apply ice packs to reduce swelling and raise a lower extremity injury. 6. Secure the splint with bandages. Reassess/record pulse, motor, sensation, PMS, distal to the injury. Monitor patient and record any changes in patient condition. 5.29 Trauma, unipolar traction splint. Sager. The student will describe the therapeutic effects of the equipment/procedure. A device for splinting and reducing pain associated with qualifying femur fractures. The student will describe the indication for the equipment/procedure. Patients with suspected midshaft or proximal third femur fractures. The student will describe the contraindication for the equipment/procedure. An associated fracture of the pelvis, hip, knee, tibia/fibula, ankle, or foot. A suspected fracture within 1 to 2 inches of any joint or partial amputation of the foot or ankle. The student will describe the possible side effects to the use of the equipment/procedure. Possibility of neurovascular injury consistent with manipulation of a fracture limb. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Explain the procedure to the patient and remind them not to move without instruction. Stabilize the leg. Expose both legs for DCA/PBLS TIC from the pelvis down. Assess/record baseline pulse, motor, sensation, PMS, distal to the injury. Carefully bring the angulated leg into an inline, normal anatomical position. If resistance is felt during realignment, stop and splint the leg in position found. Place the splint along the medial aspect of the injured leg. Attach the top strap over the upper thigh and tighten, lift the spring clip and adjust the splint so the crossbar rests adjacent to the patient's heel. Secure both ankle hitches to the patient and attach only the injured leg hitch to the end of the crossbar. Grasp the padded shaft with one hand and the traction handle with the other. Gently extend the inner shaft until the desired amount of traction. One injured leg, the device reads 10% of the patient's weight or 15 pounds maximum pull. Two injured legs, the device reads 20% of the patient's weight or 30 pounds maximum pull. Apply the Velcro straps and re-evaluate the thigh strap and ankle hitch. Apply the pedal pinion strap, figure 8, under the splint and around the feet to prevent rotation. Reassess/record pulse, motor, sensation, PMS, distal to the injury. Monitor patient and record any changes in patient condition. 5.30 Trauma, scoop stretcher. The student will describe the therapeutic effects of the equipment/procedure. Facilitates the lifting/moving of patients in limited access areas. The student will describe the indication for the equipment/procedure. Facilitates the lifting/moving of patients where minimal movement is desired, i.e., pelvic fractures. The student will describe the contraindications for the equipment/procedure. Cannot immobilize a spinal injured patient with a scoop stretcher. The student will describe the possible side effects to the use of the equipment/procedure. Patients can be pinched during the application of the scoop stretcher. Cannot X-ray through a scoop stretcher. Scoop stretcher is often cold and uncomfortable. The student will demonstrate the use of the equipment/procedure. Takes/verbalizes standard precautions. Explains the procedure to the patient and reminds them not to move without instruction. Place the scoop stretcher along the uninjured side of the patient. Align the headrest with the occipital area of the patient's head. Open the locks and extend the legs to the nearest appropriate length. Visually ensure the legs locks have seated in the rail holes and that the leg sections are secure. Open both ends of the scoop stretcher and place half on each side of the patient. Carefully place one half as far as possible under the patient. Connect the other half of the scoop stretcher carefully at the head. Slowly and carefully close the remaining half together until locking at the feet. Move patient to the desired location and remove the device. Monitor patient and record any changes in patient condition. 6.31 Patient Assessment, Medical. The student will describe the therapeutic effects of the equipment/procedure. 1. To identify all possible signs and symptoms relating to the injury or illness. The student will describe the indications for the equipment/procedure. 1. All patients. The student will describe the contraindications for the equipment/procedure. 1. Lack of patient consent. 2. Patient or scene presents an immediate physical threat to the rescuer. The student will describe the possible side effects to the use of the equipment/procedure. 1. Possible delay in care or transport time. The student will demonstrate the use of the equipment/procedure. Scene size up. Scene size up. Scene size up. 1. Park the vehicle in a safe and convenient location. 2. Takes/verbalizes standard precautions. 3. Evaluate scene safety for personnel, patient, and bystanders. 4. Consider possible etiology of problem, if trauma, establish mechanism of injury, MOI. If medical, establish nature of illness, NOI. 5. Establish the number of patients. Evaluate the need for additional resources, personnel, equipment, and special equipment. Primary assessment. Primary assessment. Control gross hemorrhage. Always stop and treat life-threatening conditions when found. Control gross hemorrhage. Always stop and treat life-threatening conditions when found. Form a general impression of the patient upon approach. Establish priorities. If patient is conscious, perform introductions, gain consent, and obtain chief complaint. If patient is unconscious or spinal injury is suspected, maintain manual immobilization of C-spine. Establish level of consciousness, AVPU, alert X4 person, place, time, event. Airway. Is the airway open? Will the airway stay open? Does anything endanger the airway? A. Ensure patient has a patent airway. B. Consider an airway adjunct and/or the possible need for suction. Breathing. Is the patient breathing? Is the patient having trouble breathing? Are the rate and depth adequate? Does anything endanger the patient's breathing? A. Rate, absent, fast, slow, normal. B. Depth, shallow, deep, normal. C. Quality, labored, normal. D. Initiate appropriate oxygen therapy. Circulation. Does the patient have a pulse and where is it located? If carotid is present, B/P is at least 60 mm/Hg systolic. A. Rate, absent, slow, fast, normal. B. Rhythm, regular, irregular. C. Quality, normal, weak thready, strong bounding. D. Skin color, temperature, condition. E. Bleeding. Check for and control any life-threatening bleeding not already addressed. E. Bleeding. Check for and control any life-threatening bleeding not already addressed. 6.31 Patient Assessment. Medical. Based on primary assessment, determine patient priorities: stable or unstable, and transport decision: rapid transport, unstable/load and go, or continued on scene assessment, stable. Significant MOI/NOI, or if patient fails primary assessment equals conduct a rapid complete secondary assessment head to toe 60-90 seconds. Non-significant MOI or stable medical PT equals conduct a focused history and modified secondary assessment. Identify affected body system and perform a focused physical exam. Determine pertinent positives or negatives with associated signs/symptoms. 1. Cardiac, onset, provocation, quality, radiation, severity, time, interventions. 2. Respiratory, rate, quality, posture/appearance, accessory muscle use, lung sounds. 3. Stroke, onset, describe episode, duration, neuro exam, facial droop, arm drift. Speech. 4. Altered mental, onset, describe episode, duration, symptoms, seizure, fever. Trauma, interventions. 5. Syncope, LOC, duration, position, HX incontinence, HX of blood in vomit or stool. Orthostatic vs. trauma. 6. GI/goo, location of pain, bleeding/discharge, last menses, blood in vomit/stool. Orthostatic vs. trauma. 7. Poisoning/OD, substance, when, amount, how was PT exposed, time period, PTs. Estimated weight, interventions. 8. Allergic reaction, HX. Of allergies, exposed to what, how was PT exposed, effects. Progression, interventions. 9. OB/GYN, pregnant, due date, last menses, para/gravida, pain/contractions. Bleeding/discharge, urine changes. 10. Psychological/social, disorder/psychiatric HX, previous attempts, ideation. Thinking about hurting themselves, environmental stressors, loss of work, divorce. Death of family member. 11. State field impression of patient and verbalize treatment plan for patient and call for Appropriate intervention, S. Rapid trauma assessment. Expose and complete a 60 to 90 second scan of the body to identify life-threatening injuries. Head and neck. Inspects and palpates for life-threatening injuries to the head, face, and neck. Inspect eyes/pupils for peril. Inspect for jugular vein distension, JVD, tracheal deviation, tugging. Inspect for deformity or tenderness to the neck. Inspect for subcutaneous emphysema. Properly size and apply a C-collar. Chest. Inspects and palpates for life-threatening injuries. Auscultate for equal and present breath sounds in 4 locations. Inspect for sucking chest wounds, flail chest, and slash or impaled objects. Abdomen. Inspects and palpates for life-threatening injuries. Palpates for tenderness, rigidity, distension. Pelvis. Inspects and palpates for life-threatening injuries. Check for deformity or stability. If C/O pain, crepitus or obvious deformity, do not palpate again. Verbalizes assessment of the genitalia/perineum as needed. 6.31 Patient assessment, medical. Lower extremities. Inspects and palpates for life-threatening injuries. Inspects, palpates, assesses pulse, motor, sensation, PMS, in each leg. Upper extremities. Inspects and palpates for life-threatening injuries. Inspects, palpates, assesses pulse, motor, sensation, PMS, in each arm. Back, done during transfer to backboard. Inspects and palpates for life-threatening injuries, head, thorax, pelvis, and back of legs. Baseline vital signs. Baseline vital signs. 1. Baseline vital signs. Assess/record a complete set of vital signs. A. Respirations. B. Pulse. C. Blood pressure. D. Lung sounds. E. Skin condition/color/temperature. F. Capillary refill, particularly in children 6Y/O. G. Pupils. H. Pulse oximetry. I. Glucose. History taking. History taking. History taking. 1. Investigate the patient's chief complaint. 2. Medical history. Question family members, caretaker, or bystanders for further information. 3. Obtain sample history. A. Signs or symptoms. B. Allergies, medications or foods. C. Medications, prescribed or over-the-counter OTC. D. Past medical history, or surgeries, pertinent to the C/C. Last oral intake. F. Events leading to C/C. 4. Obtain UpChristi for patients experiencing pain. A. Onset/origin of symptoms or pain. B. Provocation of symptoms or pain. C. Quality of symptoms or pain. D. Region/radiation of symptoms or pain. E. Severity of symptoms or pain. F. Time of onset of symptoms or pain. GI interventions done prior to arrival. 6.31 Patient assessment, medical. Secondary assessment. Secondary assessment. Secondary assessment. Full body scan if patient suffers from trauma or has altered LOC. Focused physical exam if patient's complaint or injury is isolated to certain areas of the body. 1. Head/scalp. A. Check for position. B. Check for capitals, frontal, temporal, parietal, occipital areas. 2. Face. A. Check zygomatic arch, maxilla, mandible, TMJ. 3. Eyes. A. Check pupils per law, pupils equal, round, reactive to light and accommodating. B. Check for hyphema, foreign bodies, periorbital ecchymosis. 4 ears. A. Check for blood, CSF, or other fluids and battle signs. 5 nose. A. Check for blood, CSF, or other fluids and crepitus. 6 mouth. Check for blood, CSF, foreign bodies, teeth, dentures, fluid, tissue damage, odors. Discoloration. 7 neck. A. Check for JVD, tracheal deviation, stair-stepping and medical alert tag. 8 suprasternal/clavicular. A. Check for subcutaneous emphysema. B. Check for NTG or other medication patches, pacemaker, and crepitus. 9 chest. A. Palpate sternum for crepitus, symmetry, and paradoxical motion. B. Auscultate for present and equal breath sounds, check 6 fields. 10 abdomen. A. Palpate all 4 quadrants for softness, rigidity, distension, tenderness, and guarding. B. Palpate for pulsating masses. 11 pelvis. Palpate the integrity of the pelvic girdle and pubis symphysis, do not repeat if crepitus, instability, or deformity were noted in the rapid scan. B. Check for incontinence and priapism. 12 legs. A. Check for position and length, splint fractures. B. Palpate femoral and dorsalis pedis pulses, motor, ROM, and sensation. 13 arms. A. Check for position and length, splint fractures. B. Palpate brachial and radial pulses, motor, ROM, sensation, grip strength. C. Check for medical alert tags, shunts, track marks. 14 posterior. A. Assess head, thorax, pelvis, and back of legs, if not already done. 15 Ensure patient is packaged properly and ready for transport. 6.31 Patient assessment, medical. Reassessment. 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 1 Repeat primary assessment, mental status, ABCs. 2 Repeat vital signs, unstable every 5 minutes, stable every 15 minutes. 3 Reassess chief complaint. 4 Check interventions. 5 Identify and treat changes in the patient's condition. 6 Record any changes in the patient's condition. Document any medication, dose, action, route, time, DART, and patient's response, //. 6.32 Patient assessment, trauma. The student will describe the therapeutic effects of the equipment/procedure. To identify all possible signs and symptoms relating to the illness or injury. The student will describe the indications for the equipment/procedure. All trauma patients. The student will describe the contraindications of the equipment/procedure. Lack of patient consent. Patients or scene presents an immediate physical threat to the rescuer. The student will describe the possible side effects to the use of the equipment/procedure. Possible delay in patient care or transport time. The student will demonstrate the use of the equipment/procedure. Scene size up. Park vehicle in a safe and convenient location. Takes/verbalizes standard precautions. Evaluate scene safety for personnel, patients, environment, and bystanders. Consider possible etiology of problem. Trauma establish mechanism of injury, MOI. Medical establish nature of illness, NOI. Establish number of patients. Evaluate the need for additional resources, personnel, equipment, special equipment. Primary assessment. Form a general impression of the patient upon approach. Establish priorities. Control gross hemorrhage. Always stop and treat life-threatening conditions when found. If patient is conscious, perform introduction, gain consent, and obtain chief complaint. If patient is unconscious or spinal injury is suspected, maintain immobilization of C-spine. Establish level of consciousness, AVPU, alert X4 person, place, time, event. Airway. Is the airway open? Does anything endanger the airway? Ensure patient has a patent airway. Consider an airway adjunct and the possible need for suction. Breathing. Is the patient breathing? Is the patient having trouble breathing? Are the rate and depth adequate? Does anything endanger the patient's breathing? A. Rate, absent, fast, slow, normal. B. Depth, shallow, deep, normal. C. Quality, labored, normal. D. Initiate appropriate O2 therapy. Circulation. Does the patient have a pulse and where is it located? If the carotid pulse is present, B/P is at least 60 mm/Hg systolic. A. Rate, absent, fast, slow, normal. B. Rhythm, regular, irregular. C. Quality, normal, weak thready, strong bounding. D. Skin, color, temperature, condition. E. Bleeding. Check for and control any additional bleeding. 6.32 Patient Assessment Trauma. 6.32 Patient Assessment Trauma. Based on primary assessment, determine patient priorities, stable or unstable. Transport decision, rapid transport, unstable, load and go, or continued on scene assessment, stable. Significant MOI or if patient fails primary assessment equals conduct a rapid complete secondary assessment head to toe 60-90 seconds. Non-significant MOI or stable medical PT equals conduct a focused history and modified secondary assessment. Rapid trauma assessment. Expose and complete a 60 to 90 second scan of the body to identify life-threatening injuries. 1. Head and neck. A. Inspects and palpates for life-threatening injuries to the head, face, and neck. B. Inspect eyes/pupils for peril. C. Inspect for jugular vein distension, JVD, tracheal deviation, tugging. D. Inspect for deformity or tenderness to the neck. E. Inspect for subcutaneous emphysema. F. Properly size and apply a C-collar. G. Inspect subclavicular area for subcutaneous emphysema. 2. Chest. A. Inspects and palpates for life-threatening injuries. B. Auscultate for equal and present breath sounds in bilateral upper fields. C. Inspect for sucking chest wounds, flail chest, and slash or impaled objects. 3. Abdomen. A. Inspects and palpates for life-threatening injuries. B. Palpates for tenderness, rigidity, distension. 4. Pelvis. A. Inspects and palpates for life-threatening injuries. Check for deformity or stability. If C/O pain, crepitus or obvious deformity, do not palpate again. C. Verbalizes assessment of the genitalia/perineum as needed. 5. Lower extremities. A. Inspects and palpates for life-threatening injuries. B. Inspects, palpates, assesses pulse, motor, sensation, PMS, in each leg. 6. Upper extremities. A. Inspects and palpates for life-threatening injuries. B. Inspects, palpates, assesses pulse, motor, sensation, PMS, in each arm. 7. Back, done during transfer to backboard. Inspects and palpates for life-threatening injuries, head, thorax, pelvis, and back of legs. Package patient and determine transport decision. If not critical, obtain baseline vitals and sample history. If critical, log roll onto unaffected side and onto backboard, package properly and ready for transport. 6.32 Patient Assessment, Trauma. History. Investigate patient's chief complaint. Medical history question, family, caretaker, bystanders for further information. Obtain sample history. S. Signs or symptoms. A. Allergies, medications or foods. M. Medications, prescribed or over-the-counter OTC. P. Past medical history, or surgeries. L. Last oral intake. E. Events leading to chief complaint. Secondary assessment. B. Pulse. C. Lung sounds. A. Respirations. Baseline vital signs. Assess and record a complete set of vital signs. A. Respirations. B. Pulse. C. Lung sounds. D. Blood pressure. E. Pupils. F. Skin condition / color / temperature. G. Capillary refill, particularly in children 6Y/O. H. Pulse oximetry. I. Glucose. Full body scan, detailed physical exam if time allows. Focused physical exam, if complaint or injury is isolated to a certain area of the body. Head. Inspects and palpates mouth, nose, and assesses facial area, zygomatic arch, maxilla, mandible, and TMJ, for DCAPBTLS tick. Inspect and palpates scalp, frontal, temporal, parietal, and occipital areas, and ears, blood, CSF, and battle signs. Assesses eyes for perla, pupils equal, round, reactive to light, and accommodating, raccoon eyes, high FEMA, foreign bodies. Neck. Inspects and palpates cervical spine and neck for DCAPBTLS tick, if C-collar not applied. Checks position of trachea. Checks jugular veins and subcutaneous emphysema. Chest. Inspect and palpates chest for DCAPBTLS tick. Auscultate for present and equal lung sounds, check 6 fields. Check for medication patches, pacemakers / defibrillators. Abdomen. Inspect and palpates all 4 quadrants for DCAPBTLS tick, rigidity, distension, and guarding. Palpate for pulsating masses. 6.32 Patient assessment trauma. 6.32 Patient assessment trauma. Pelvis. Inspects and palpates pelvic girdle and pubis symphysis for DCAPBTLS tick, if already done and unstable do not reassess. Inspects genitalia / perineum, incontinence and priapism. Lower extremities. Check for position and length. Inspects and palpates for DCAPBTLS tick. Assesses pulse, motor, and sensation, PMS. Upper extremity. Check for position and length. Inspects and palpates for BCAPBLS tick. Assess pulse, motor, and sensation, PMS. Posterior. Inspects and palpates head, thorax, pelvis, and back of legs, if not already complete. Reassessment. Repeat primary assessment, level of consciousness, A, B, Cs. Repeat vital signs, unstable every 5 minutes, stable, every 15 minutes. Reassess chief complaint. Check interventions. Identify and treat and changes in patient condition. Record any changes in patient condition. Document any medication, dose, action, route, time, DART, and patient's response, // Palm Beach State College. Emergency Medical Technician. Commonly used mnemonics / abbreviations. AVPU. A. Alert. V. Responds to verbal stimuli. P. Responds to painful stimuli. U. Unresponsive. DCAPBLS tick. D. Deformity. C. Contusion. A. Abrasion. P. Puncture / penetrations. B. Burns. L. Lacerations. S. Swelling. T. Tenderness. I. Instability. C. Crepitus. MOI. Mechanism of injury. NOI. Nature of illness. Upcrusty. O. Onset. P. Provocation. Q. Quality. R. Region / radiation. S. Severity. T. Time of onset. I. Interventions. Perla. P. Pupils. E. Equal. R. Round and R. Reactive to L. Light and A. Accommodating. PMS. P. Pulse. M. Motor. S. Sensation. sample. S. Signs and symptoms. A. Allergies. M. Medications. P. Past medical history. L. Last oral intake. E. Events leading up to. S. Signs and symptoms. A. Allergies. M. Medications. P. Past medical history. L. Last oral intake. E. Events leading up to. mm/Hg millimeters of mercury, e.g. blood pressure of 120/80 mm/Hg. mg/dl milligrams per deciliter, e.g. blood glucose is measured at 82 mg/dl.